My name is Reinhard Busse. I'm by training a medical doctor, then did a degree in public health, epidemiology, health services research, qualified in several countries, and then 10 years ago I became professor of healthcare management here at the Berlin University of Technology, and my focus areas, even though we are really broad, we are in international health system comparisons, health service research, health economics, and health technology assessment. So very broad based research into health and healthcare.
Thank you for giving us an interview. Now, we know about cancer as a heterogeneous disease, and the more we unravel the genomics of the cancer process, the worse it gets. You're interested in heterogeneity of cancer outcomes on a sort of national and international scale, and your results don't make very attractive reading. Tell us about them.
Well, I think we are not only interested in the outcomes, but that is, I think, what the population, what the patients, what the policymakers should be primarily interested in. And of course, come back to the outcomes in a minute, then we are interested, why do we see these different outcomes? Is it that healthcare systems are differently organized, differently financed, they have different numbers of physicians and so on? And it's not my own data I'm reporting on, but the data of the OECD. And the latest data show that when we look into very common cancers, of course, taking them as entities, let's say cervical cancer, that the 5-year survival rate, so of patients who have been diagnosed, how many of them live 5 years later, differ greatly within Europe. So when you compare Norway, for example, in Norway, almost 80% still live after 5 years, while in Ireland only 60% live. 20 percentage points difference already sounds large, but then when you look from it from the 100% standpoint, I mean, in Ireland, twice as many people as in Norway don't survive. Sure. So I mean, so these are huge differences, and we see similar differences also for breast cancer and for colon cancer. So always the differences in really the chance of not surviving are always around the factor 2 within European countries.
Now, of course, the cervical cancer example is particularly galling because we've, of course, got a vaccine, which if administered better than the screening program clearly is being administered, then this would improve figures and maybe bring them all up to an acceptable standard.
Well, I mean, that is the other, I think that is the second issue, is how is the development of the outcomes over time. And for cervical cancers, clearly 5-year outcome rates we can only observe retrospectively. So we currently look at the data from the 1990s and the data from the mid-2000s. And actually for cervical cancer, unlike colon cancer, survival rates, at least from the 90s to the 2000s, did not improve overall. Whether now the new immunization will make it different, we have to see. Clearly, we can then not take the 5-year survival rates because prevention will not even, let these people develop the cancer, but we should see that in the population-based mortality.
Sure. And breast and colon?
Breast and colon is, I mean, the development across countries was better, so we saw better improvements, but again, we still see a big variation among countries. For these two entities, also non-European countries like Japan is doing very well. Yeah. But again, like for cervical cancer, Norway is doing quite well. On the other end of the spectrum, we have countries like the Czech Republic, Slovenia, but again, Ireland and the UK is also not doing that well.
Sure. I mean, in the UK, people are trumpeting about the improvement in in breast cancer outcomes. But if you look back to where they started, they're much, much worse 25 years ago. And indeed, there has been an improvement, but there needed to be, because 25 years ago, Britain was behind Estonia, as I recall. And so things have improved, but they haven't improved enough, and that's your message.
Well, the countries on the lower end, they should be improving much faster.
Yeah.
And I think the question then is, why are they so far behind? Is it really only the available treatments? Is it the available drugs? And then clearly we would say, okay, the treatments existing are the same. One question is it the access to the drugs? But probably more so, it is the organization of the cancer care. For example, in Norway, they concentrate the cancer care. And I think we really need to, and that was also one of the outcomes of the panel we just had, we need to look at organizational technologies, concentration of care, cancer networks, guidelines, in a way as we usually look only on drugs. Because maybe we only look into new drugs, but if, let's take again the example of Ireland, if they would organize their care as Norway does, they could double their outcomes without even investing in new drugs.
Sure. I'm personally completely convinced that organizational solutions are the way to make the next step forward, particularly for countries where individual surgeons, for instance, still do breast cancer and colorectal cancer operations. This is absolutely unacceptable in 2012. And the UK has been very slow. Surgeons have been very resistant to the idea that they should form teams, as they do in Norway and all the Scandinavian countries, also Holland as well. How do you propose getting these messages over?
Well, I think it's important that we realize that there are these data. I mean, and I see really improvement. I think it's really in a meeting like here we see that the clinicians, the oncologists meet with people who come more from health services research, health economics, and I think both sides have something to offer. And it's important to realize that we have a multitude of evidence and that we have health technology assessment, and health technology assessment needs to rely on good clinical data but also economic data, and then we need to have registers and the routine data. I think, I mean, we collect in all countries so much data on hospital episodes, death registries, but we don't link them. No. So I mean, for example, I mean, if I know that in Ireland 40% have died after 5 years, I would like to know these 40%, were they treated differently on average than the 60% who survived? So maybe it's really the result of an omission, possibly also of overtreatment.
While also in some of the studies we've done in the UK, comorbidity has been a factor when you're looking at poorer survival in groups of the population, and the less well off get more cancer, and they do worse in almost every country.
Well, that's true. And I mean, I should emphasize that these data by OECD are at least age standardized, so that they take certain effects out. Clearly, they cannot standardize for everything because we don't have all the information included. But let's say it would be the effect of greater inequity in one country.
Absolutely.
Then
Absolutely.
It's also important that we know that, and maybe then it's the non-health care related components which need to be addressed first. Maybe they have a two-tier system, different co-payments and so on. Maybe that is the solution rather than the cancer surgeons.
And those imbalances and inequities are growing, unfortunately, in most of the European countries. Thank you so much for giving us your time and your advice. A very, very interesting topic, and we'll have to keep coming back to it at subsequent fora.
Thank you.